our next presenter is Gurpreet Padam, and she's going to present home-based medicine.
Hi, thank you so much for this opportunity. And it's incredibly humbling to be here and very exciting to be with you all. We are home-based medicine, compassionate care, compassionate primary care for the homebound. And we are physicians, we are physician-led, and we are physician-driven concierge primary care. And we bring that to the home of homebound patients. And I'm Gurpreet Padam, and I'm a family and a palliative medicine physician, and I have a track record of identifying shortcomings in the system and persistently working towards sustainable solutions. Prior to medical school, I was a home respite worker for children with autism. And then after residency as my first job, I initiated an inpatient palliative care program at Kaiser River City, and we expanded it into a successful outpatient and eventually home-based primary care program. I co-founded a national nonprofit and a free clinic for the uninsured, which continues to be successful. And we serve about 1,000 patients annually. And I was invited to serve on the nonprofit board of Global Telehealth Network, and I currently serve as a board president for Rota Care Bay Area, and we operate 10 free clinics in the Bay Area, serving about 5,000 patients a year. And I'm here today with my partner, Dr. Sangwan, and she's also here on Zoom, and she's an internal and a lifestyle medicine physician with over 2 decades of experience in the outpatient and inpatient setting, and is running a thriving primary care business since 2013. She understands the business of medicine and the intricacies of navigating a complex system. She's my motivator and cheerleader, and she's the inspiration that nurtures the support of our daring dream. And together, we launched this program about 3 months ago, and we have over cumulative 4 decades of experience between the two of us. And we bring in our expertise, perspective, and learnings. And we are offering services locally as we have roots in this community in the Bay Area. And we know the local physicians and providers who we work really well with. And we know that we all make an impact together. And I also have comfort companion who often accompanies me on my home visits. I wish I could show you her picture. And so you would ask, well, why require a hands-on model and not just a virtual medicine or remote case management? Well, telehealth is a very effective tool for the diagnosis and treatment of many conditions, but it is not a substitute for in-person care. And primary care can't be 100% virtual. Remote patient monitoring without the intervention of a PCP fragments care. And home-based models in the traditional setting aren't sustainable. And studies show that homebound patients can't access virtual care access virtual care for various reasons. And nearly a quarter of Americans with a disability never go online, and only half of them use the internet daily. Add on the cognitive, dementia, physical limitations, loss of hearing, vision, and makes the situation more complex. And about 70 to 80% of people with advanced illnesses wish to die at home, but only 25% actually do, because they don't have the access to transition of care, because it's only available to them if they go to the ER or admitted to the hospital. And of course, that adds to the cost of care, which could have been avoided. We provide concierge service, personalized primary care, and not just home care in the comfort of one's home. We seamlessly incorporate lifestyle medicine, palliative care, quality, convenience into our practice model, and we offer flexibility. We offer the same day or next day home visits by video, phone, or home, and we provide continuity and consistent care using a pod model, which is a small team, and that knows the patient and the physician and families, and it's the same team that the patient will interact with every time. We provide direct access to the team and to the team physician, and our communication is seamless. We offer texting and electronic medical record access and after-hours call center. And we offer coordination of care. and collaboration of care with providers involved in the patient's care. And we discuss goals of care, bringing personalized plan at the very first visit and incorporate intentional, compassionate based practices. And I'll give you an example of a 92-year-old we had in an independent living, followed her course of worsening dementia and maximized her quality of life with physical therapy and caregiver training. She was starting to aspirate. We were able to get in mobile imaging in her home. We treated her aspiration pneumonia at home. And a few weeks later, she needed a face-to-face visit for placement. She was declining. And we transferred her to custodial care, where she had a smooth transition to hospice and passed away with her daughter at her bedside. We treat urgent issues at home as preventative care that may otherwise end up in the ER, such as infections, urinary infections, aspiration pneumonias, bed ulcers, pressure ulcers, fall evaluation, placement evaluation. And our secret sauce is us. We have the training, tools, skills, background, experience, the business savvy, 4 decades of combined experience. We know what works clinically and financially. We offer convenient, timely, appropriate care to patients when they need it, intervene early, and we prevent premature suffering and death. And we are poised to deliver. In the next decade, we are the chronic diseases are going to they already take up 90% of the total national healthcare spending, and our interventions are designed to be more cost effective, reduce the number of unnecessary hospitalizations, rehospitalizations, and improve patient outcomes, patient satisfaction, functional status. And research already shows us that home-based medicine accomplishes all these things and avoid any unnecessary procedures and get patients what they want, the kind of care that they want, where they want it. Our projected success, are we scalable? Are we sustainable? Yes, so we have a small pod, and our income generates with a 1 physician, 1 MA, 1 social worker with 250 panel patient. And as we grow, we plan to add advanced practitioners as physician extenders. And we have teams planned by demographics. We are a small private company feel with local physicians in the community that people trust and know and connect with and become part of our community. So for a staff member, that would end up being 5 home visits per day, working about 220 days a year. And if each patient was seen at least 4 times a year, that's 1,000 visits for 250 patients. And in California alone, there's nearly 1 million disabled who cannot function independently. And just in the San Mateo County, where we're located, we have over 60,000 people over the age of 65, and 7,000 of them are over the age of 85, the fastest growing patient demographic in healthcare. And we want to be sustainable and scalable and not grow too quickly, so that we are providing high quality care, satisfaction to patient families and care teams, and demonstrate about 1 to 2 years of sustainable growth before we aspire further, and only launch practices with smaller teams that are local to keep that personal feel. And we're here to revolutionize healthcare delivery, invest in primary care in the form of house calls, which have the potential to revolutionize the quality, the care, the cost savings, the satisfaction, and because we are treating the sickest of the sickest. Together, we can cultivate and achieve optimal health for all. And we want to do what we do best, is take care of each other. And that's why we're here today. And I will end with that. Thank you. And we're open to questions.
Thank you so much for that, Dr. Padam, especially that stand and deliver, right? You never know what you're going to be armed with when you finally get the stage, and you handled that gracefully. So that was awesome. Keep that up.
Thank you.
Thank you. Now I want to ask you just a basic question, which is, if I'm a venture capitalist, I know that most of my bets are going to fail. So any of my bets need to be on an opportunity that has some kind of potential for explosive growth. Can you tell me how, a $100,000 investment is going to go 100x with you guys?
Yeah, absolutely. And I'm going to invite Seema Sangwan to help answer that question with her business savvy. Seema? Can't hear you.
You're still on mute, Seema.
Thank you. Can you hear me now?
Yes.
All right. So Tori, thank you for question. Yes, we've done the finances of running the business. I've run the primary care practice for almost a decade now. And running with these numbers, if a PCP or home-based physician sees 1,000 encounters per year, they will generate about, including the concierge fee, about 900,000 in a year. And their take-home income is, Bay Area income is about 350 per physician, and rest is left for overhead and profit margin for investors, right? Overhead for any PCP practice is about 50%, but that's a lot of office space and equipment that we get. So overhead for a mobile or home-based company will be less than 50% based on the projections. So even if we say another 200 for 2 employees, one person who's taking the phone calls, 1 social worker, is about 200. So the expense for that 1,000 encounters is about 550, and out of 900 rest is your revenue. So if we explode, say if we go even from say 1 physician pod to 10 physician, every physician will be generating that about 350 per year. And this is where a physician is not being overworked to the point of 80 hours per week. When you see about 6 patients per day, you're literally spending 8 hours at work. So the physician burnout is not there. You don't lose physicians. In healthcare, we lose a lot of money in attracting more physicians. Physicians come in, we lose them. So the overhead and maintaining the business will be less expensive, and every physician will make certain amount of about 350 of profit to the company itself.
Thank you.
You're welcome.
Can you go into a little bit more detail about the model? You mentioned, I think, a subscription model. Does that get you a certain number of visits a year, or is each visit billed separately? Is this completely outside of insurance and self-pay? Talk about that a little bit.
Yes, so initially this model started from San Mateo Primary Care, which is a concierge business. We kind of modeled it after MDVIP. So we do charge concierge fee per year, and for this program is $3,000 per year. And we are committing to at least 4 visits, in-home visits per year. And we are committing to unlimited texting and support from the social worker and the team. And we are still figuring out how many video visits we can do. So far, we are doing unlimited visits and support to the family members. So we do bill in addition to that. The contract says the services we are providing, they're outside the Medicare coverage. So we do bill Medicare in addition to the concierge fee. So in this model, so if we charge $3,000 per patient, Medicare, we really were conservative in projection. Even with 4 visits, we decided it'll be about $600 to $700 per patient per year, which is at the very lower end of Medicare reimbursement for advanced care planning, chronic care management, and the visit itself. So it might be a little bit higher. Was there other part to the question?
No, that answers the question. Thank you.
I sort of have a little bit of a follow-on question, and this might just be me with a little bit of ignorance and understanding some of the socioeconomic barriers. When you're looking at $600 to $700 per patient per year, that seems like a pretty low cost for concierge medicine, which has historically really been available to people with means, with higher means. But how does this really serve like some of those lower income patient populations? Because that amount could also maybe be out of reach for them. So what have you guys seen so far?
So $600 to $700 is Medicare reimbursement, Susie.
Oh, okay,
we're charging $3,000 for concierge per year. And
so what's coming out of a patient pocket? Like if I'm a patient of what's the average?
That's $3,000 per year coming out of patient pocket. And most
Okay.
Medicare patients will have a secondary coverage or Medicare Advantage that covers 80% plus the secondary will cover 20%. So for Medicare plus secondary patient, nothing else comes out of their pocket because all of their services are covered.
Okay, perfect. Thanks.
And when you ask about can lower income people afford it? We are starting in Bay Area, right? So even at the affordable housing,
People can't afford.
they need to be able to afford that monthly rent, which is not less than a couple $1,000s. And if you look at assisted living, the minimum I can find in this area is about $6,000 plus the cost of the caregiving. Bay Area people can afford it. And if you want to expand, ultimately our goal will be to have contract with the local HMO plans, the local groups that are IPA, where they are spending a lot more money on ER visits, on the hospitalizations, right? They're spending way more than $3,000 when those patients, when they have assigned PCP as HMO patient, they can't get access to that PCP, right? They have aspiration pneumonia, they have UTI. So we can show that just by preventing one ER visit, we save that $3,000, right? And those studies have been done. So our goal as we expand will be to contract with insurance plans to say, we are taking the risk. We'll at least save 3x more than what we are charging you. And if we can't prove it, then you don't have to contract with us. But we'll have data going forward because we just launched this business home-based specifically 3 months ago. So we have very little data, case studies, more like 12 ER hospitalization preventions. But that's the ultimate goal where everybody can afford it because insurance, instead of paying per encounter, they're going to pay for the risk assumption.
Yeah, and each hospitalization averages about $10,000 a day, and ER visit can cost for a simple UTI anywhere from $123 to about $2,000 to $3,000. So we're intervening early, preventing things from getting worse, and keeping patients at home where they want to be. And if they want to be elsewhere, it's our job to make that happen based on what it is that they want, the kind of care and the intensity of the care they want.
Lavinia, now you're muted. There you go.
I know, I was commenting with you, Lee, so we had some questions of our own. So there are a lot of small companies that do a similar job that you are doing. So how do you plan to scale, and are you gonna take over or just build up?
There's not enough competition yet. If there was, then there will not be still 80% people wanting to die at home and still only 20% getting that service, right? Again, a lot of companies are saying, RPM company will say, remote patient monitoring company can say, well, what are you doing different? We are providing these services at home. And CCM company can say the same. We are doing home visits. What are you doing different? And every time a company does part of the primary care and says we are physician-led and we coordinate with primary care, they fragment the care even more. They increase the cost more. How many times, well, you're not PCP, but as a primary care physician, when I get the notes that are 10 pages long, how many times am I expected to read all those 10 pages of notes and actually pay attention and make meaningful changes in the patient care? Very, very rarely, right? Because I'm seeing additional 15 patients as a traditional PCP, right? So all the companies, if you look at their financial data, their projection, again, my knowledge is probably a kindergartner, but when I look at other companies who say we are doing the same, most of them are not. They are taking a part of the primary care and they are saying we are doing it. They're not. And we are involving everybody under one umbrella.
I think it depends on the area too. So you have to find the areas that are underserved. But yes, I think it's a booming business. And
yes, absolutely. Yeah. And of course, the more the companies are in business, more we strive to do better. Competition makes us better. Right?
And we would still not be able to serve the needs of everyone who need them if 10 other companies erupted who would offer the same as us. And I'll tell you, just a couple of years ago when my dad was homebound, as a physician, I'm very resourceful. I left no stone unturned to get him a physician to come into the home so he could be qualified to get the home health services he needed, physical therapy, and I couldn't. I called Medicare, and this is in Illinois, and well-to-do family, and I couldn't find anybody. So I ended up doctoring my own dad instead of being a daughter by his bedside and being with him on his last days. I had to doctor him because the service didn't exist. And we want to make sure that other people have the opportunity to be families with their families and leave the doctoring to us. We don't want others to suffer. As I can tell you, the suffering that my family endured, I don't want anyone else to go through that. And therefore we bring that motivation and our intention behind the work we do.
Thank you. The personal story always adds to the presentation. So thank you. So